Hi, good afternoon, and welcome to the annual national conference. I'm Sam Masterson, and I serve as the president and CEO for the Myasthenia Gravis Foundation of America. And I am so thrilled to invite you all here today. And thank you so much for taking time out of your schedules and for feeling this is a very important conference to attend and be a part of. This is by far the largest program that MGFA does host. And with that said, we offer a lot of different types of programming, but this program in particular actually brings several hundreds of people together, friends together from around the world, which is so impressive, and we want to welcome you all. But this conference doesn't just happen. It takes a lot of stakeholders. It takes all hands on deck. And so right off the top, I really want to thank all of the speakers who are going to present today and over the next few days. I want to thank our corporate partners, our funding partners who are there to support anything that we do. And I want to thank certainly our board of directors who are always supportive of our efforts. And I want to thank the staff because the staff has planned for many, many months to put this program together. And in particular, Dove 11, who has been the staff lead person on this conference. I want to thank her for her time and her efforts in putting this together. But we could not do it alone. We have to lean into our volunteers, our medical professionals who lend their expertise. We have to lean into our community members, the patients, their caregivers, their family members who lend us critical insights into what you want to hear about. It's the right information at the right time. And so I hope you're really excited about this agenda over the next 3 days. I know that we are. So I want to thank our partners off the top, certainly the speakers that I mentioned, and all of our sponsors. And I want to thank our board of directors who are tuning in. And the entire MGF staff is also here for the next 3 days. So I encourage you to interact with them every chance you get. You'll see them around. A couple housekeeping things right off the top that I want to discuss with you guys. I think these will be helpful tips for you guys to know for the site. Of course, if I'm just talking to you, I don't need my glasses, but if I'm going to read some notes, I need my glasses. So as you enter the conference, you are in the lobby. If you ever need to get somewhere, and I think this is really helpful information to know, if you ever need to get somewhere or just reorient yourself about the site overall, go back to the lobby. The lobby is a good place to be because you can get to anywhere on the site from the lobby. For those of you who joined us last year, because it's our second year in a row going virtual with this conference, it will all come back to you. I promise you that. I've been on this morning and I didn't remember everything, but I've been able to navigate my way around. So it will all come back to you. For those of you who are new joining us this year for the first time virtually, I'm going to walk through some things real quickly with you that I think will be quite helpful. So the lobby is the first place that you come into that you enter this conference. Across the top will be your navigation. You'll see a lot of obvious tabs that will present different places that you can go within the platform. The main room where you will spend most of your time is called the theater, okay? That's where each session takes place, where you'll hear each of our speakers. You will need to leave the theater. When a session wraps up and you want to go to the next session, you'll need to leave the theater and then go back in. That's a very important thing to note and to remember, okay? So once you listen to a speaker and they've wrapped up, it's just going to be silent. Nothing else, nobody else is going to come on. So you have to click out, leave that session. You'll go back out. You'll see the menu of speakers, the agenda. You click into the next session. That's a really important thing to remember. There is a help desk. So should you need anything, whether it's technical or you just need to reach a staff member, you can click on help desk. The tab is actually labeled help. There's also a tab called resources. And this is where you can find fact sheets and brochures and all sorts of information on upcoming webinars that can be helpful. And then, and this one's really cool, at the top of your screen, you'll see a briefcase icon. So you'll be able to download any documents that you'd like to have next to resources. Any resources, any brochures. There will be a save button, and all you need to do is click on that save button. And the resources that you have selected will go directly into your virtual briefcase. And then you'll have all those documents downloaded for yourself. And then lastly, I'd like to encourage you all to please take the time to visit our sponsor booths. This is a tab at the top of your screen called Exhibit Hall. This is where you'll find all the sponsor booths. Our partners are very eager to meet with you all, to share good information, and to certainly answer your questions. And there is also a new feature this year, which is a video chat, which some of our sponsors are taking advantage of. So you'll be able to speak with them live, which is pretty neat. So those are all of our housekeeping tips. Again, should you need anything at all, click on the tab called Help, and you can find a staff person or you can find some technical help, and somebody will walk you through whatever needs to be done. If you're having any issues, always remember to refresh your browser at the top of your screen. That always seems to take care of things. I was actually just told this morning that takes care of 99% of things, so remember to do that if you feel like you're in some technical trouble. And now, without any further ado, I would like to introduce somebody who is certainly very special to MGFA, and that is Nancy Law. Nancy currently serves as the chair of the MGFA Board of Directors, but previous to taking the chairmanship for MGFA, she served as the organization's first CEO. Nancy served as the Chief Executive Officer from 2016 until early last year in 2020, when she officially retired and I transitioned in as the new CEO. I am extremely grateful for Nancy, as I know the entire team is, and I am so happy that she is still so involved with the organization, and she is such a good partner. So please join me in welcoming Nancy Law, who's going to officially kick things off for us.
Thank you, Sam, for that kind introduction. It really is an honor to serve with you on behalf of the MG community in what is probably the most exciting time in our history. And hello to everyone who is joining today for what I think is MGFA's 44th annual conference. This is our second online meeting, and through the magic of the internet, we're able to reach MG patients from around the world. Welcome. I have the distinct pleasure of introducing our first speaker, Dr. James Howard, known as Chip to most, to help us kick off the 2021 conference. Chip has been a friend of the organization for more than 40 years and has worked tirelessly on behalf of MG patients. I like to say for the worldwide MG community, he's our equivalent of Cher or Prince or Beyonce. One name is enough. He is so renowned amongst MG clinicians and scientists that when somebody says, well, Chip says, everyone knows who they're talking about and everyone stops to listen. While Dr. Howard recently retired from seeing patients, he's not retired from his tireless work for all of us with MG. He continues to be a teacher and mentor for many young investigators. He has served as the principal investigator on several past and current clinical trials and is an advisor to many others. And I cannot begin to count the number of hours he has unselfishly volunteered to support the MG community and the work of MGFA. Dr. Howard will be presenting today on a topic important to all of us, the session entitled SARS-CoV-2, What It Means for the Myasthenia Gravis Patient. Welcome, Chip, and thank you for being here with us today.
Well, thank you, Nancy. You're sort of taking my breath away. Greetings, everyone, and welcome to the Myasthenia Gravis Foundation national meeting. And as Sam said earlier, I hope this is of tremendous benefit to you. We're going to talk about an episode, an event that has been a disaster to all of us. But before I start, I want to offer our thoughts and prayers to our patients who are out in the Caribbean, who are also suffering from the volcanic eruptions on St. Vincent. I know several patients in the Barbados area who are trying to attend this conference but can't because they have no power. So our thoughts are with them. We're going to spend the next bit talking about SARS or COVID-19, as it's also called. And much of this may not be new to all of you or some of you, but I want to review and give you a sense of where we stand. This is how I see what COVID has done to us. And every day is the same day. As we've all hunkered down in social isolation, the same four walls, the same floor, the same ceiling, and it's clearly had a devastating toll mentally, physically. We've all at least gotten the COVID-19 pounds, and we have weathered this over the last year plus, and hopefully the future is brighter. I know the future is brighter, hopefully sooner rather than later. These are my requisite disclosures, and as Nancy said, I consult with several pharma companies. None of what I'm going to talk about today is of any conflict of what I do. So what's a coronavirus? Well, it's a family of viruses that affect the respiratory tract. It causes disease from anything as minimal as a common cold-like problem to severe pneumonia. And we all know of patients who have felt the ravages of this disease. It typically originated in bats and other wild animals and then jumped, as we say, to humans. There's controversy as to where this came. I don't have an answer for that. I don't think we're going to get an answer in the immediate future. And then it's transmitted to humans directly or through other animals that we come in contact with, whether it be food sources at an open market or else. It's that kind of a transmission. And then it's transmitted human to human. And this is where we as a community around the world have to take pause and notice. And it's transmitted through respiratory droplets, through coughing, through sneezing, through singing, through yelling, even through speaking. And we'll get into that a bit more as we go. So what is COVID-19? So COVID-19 is a new strain of coronavirus that was first identified in 2019. And these coronaviruses are a huge family of viruses of many different kinds. And as I already said, they cause diseases ranging from a very minimal cold to SARS, the severe acute respiratory distress syndrome, to MERS, which is the Middle East respiratory syndrome, which we've had experience, the community, over the last several years. And then this newly identified coronavirus, SARS-CoV-2, is what's causing this worldwide pandemic of respiratory illness that we have shortened to COVID-19. It's actually about the 289th, 290th pandemic recorded, the first occurring in 1200 BC. And there have been 6 other pandemics since COVID-19 started a year ago. Where do we stand today? Well, we're now, since I put these figures together about a week ago, we're now over 131 million cases worldwide, with 2.9 million plus cases in the United States. We have 2.9 million deaths worldwide. We have 30 million cases here in the U.S., with over 500,000 cases who have passed on. And those are astronomical numbers. Little did any of us think in my generation, in younger generations, that we would ever encounter something like this. Our grandparents did at the turn of the century with the Spanish flu and all, but we never envisioned this ever happening, and it has. And it's altered each and every one of our lives, not a little bit, but a tremendous amount. So what is a pandemic? What is an epidemic? And I want to get these terminologies straight because when I talk to patients and friends, etc., terms are misused, and that can be confusing. So an epidemic is a widespread occurrence of an infectious disease in a community at a particular time. So we have an epidemic of, say, hepatitis because of contamination of food sources that strikes a local community. It's concentrated, it's focal, it doesn't have any effect on the county, the state, the country, or the world. Pandemic, on the other hand, is an outbreak of a disease that occurs over a larger territory, such as a country, and even worldwide. And we're seeing this pandemic. So therefore, a pandemic is an epidemic that has just geographically spread over a much larger territory. The US, say, or all of Europe, or as we're now experiencing, the entire world itself. These are a list of known pandemics. In terms of, I've ranked them here in terms of mortality. So the Black Death took out nearly 200 million people, nearly 30 to 60% of the entire European population in the 1300s. The Spanish flu, which we had at the turn of the century, took out nearly 100 million people, 5.4% of the world population. Huge numbers. And you can see the others. The HIV/AIDS epidemic, 35 million deaths as of 2000, all since 1981. I listed COVID-19 as the 19th, or as the 12th there, as you can see. But as of figures of this weekend, it's now moved up into the 9th position in terms of overall mortality. And so it exceeds the others that I've listed there on the slide. These are huge changes in our populations around the world. And the terror, the sickness, the ill health, the impact economically to the world is devastating. And it takes eons, decades to recover from these things. Now, is modern day better than the past? Perhaps. And we'll have to see. We now have tools to combat this. We'll get into this as we go, that hopefully will make things easier for each and every one of us. But there's no question that it has taken its toll throughout the world, as we know. Where do we stand? Well, we're number 2. Brazil is the worst currently. We follow a close second, and India is third. And India may overtake us given this most recent surge in cases that they are now experiencing and a breakdown in their ability to vaccinate patients. And all these other light blue dots scattered around the world show the density of the infection. The larger the circle, the greater number of the cases. And you can see in Australia, they've had less than a handful of cases. When they recognized the virus, they shut their entire country down, and parts of it are still shut down as they try and control this. They've probably done the best job, but as you can see, travel to and out of Australia is a bit more difficult than through the States and through South America and Europe, etc. What's wrong with this picture? This was taken about 2 months ago. One sees mass accumulations of people here. And why? Well, this was Franklin Street in my hometown here in Chapel Hill, North Carolina on February 6th, moments after we beat Duke in men's basketball game. The Duke-Carolina rivalry is legendary. And this Franklin Street, after 2 years ago, 100,000 people were on the street. Here, much less, but clearly all of these students here maskless. And so the rules that we need to live by are the 3 W's, as we say in the state of North Carolina. Wash your hands frequently. Wait, that is to maintain 6-foot distances, social distancing, and wear a mask. And probably I would add a 4th, and that's to keep your fingers out of your nose. The greatest reservoir of this virus is your nasal cavity. And by manipulating your nose and then touching things, you clearly have the capability, if you're so affected, to transmit this disease. One should avoid crowds, stay outdoors where it's safer, keep your bubble close. We all now talk about our bubbles. Keep them close to you, don't expand them if at all possible, and avoid travel. Now, all of these rules are changing, even as I speak. The CDC is modifying these rules, and that's appropriate. As we learn more, we alter what we believe and what we recommend and what we do. Travel in selected situations is safer than it used to be and is probably appropriate, but one needs to respect these other rules and be cautious. And the last one is to get vaccinated, and we're going to spend some time talking about that because I know there's controversy in this regard. Another terminology or term that we need to come to grips with is what we call R naught. And every week I see documents prepared by my hospital as to what the R naught is, and as we anticipate how many patients we're going to see hospitalized, and what does that do to our bed capacity, not only in the ICUs, but in our other wards. And the R naught is a mathematical term that gives insight into the infectivity of the virus or the bacterium. It tells us about an average number of people who are going to contract this disease from one individual who has the disease. And one can see, and I need my glasses because I'm on a laptop here, that influenza has an R naught of 1.5. So we anticipate 1.5 people are going to become infected if they become exposed to someone. Hepatitis, for instance, or measles rather, is 16, highly contagious virus. And that's why all of our children are vaccinated before they go to school, and colleges don't let you in unless you've had a series of vaccinations. In the past, smallpox, the scourge of smallpox, had an R naught of 6, and rubella 6. COVID-19 is 2.5, so much less than some of these others, but clearly it's not 0, which means an individual can't infect anyone else. So we're expecting 2.5 individuals who have coronavirus to be infected from someone who's got the infection. Now, as we apply our 3 or 4 W's, as we increase vaccination, as we keep our bubbles tight, that R naught falls. And so this is a mathematical term that's used as we look at graphs that I get every week, looking at what the R naughts are and what our projections as we predict what the infectivity is going to be over the next 5, 6, 8 weeks as we try and predict what resource utilization we need to have at our hospital. So here's some graphs. And on the upper right on the top graph is an R naught of 1.1. And so one sees that we start with, fairly 0, and very quickly we can infect 25,000 people over a fairly short period of time versus someone with an R naught of 0.5, which is the bottom line, which is fairly flat. So multiple exposures and only a half of a patient or one individual if they're exposed to 2 people simultaneously, for instance. And the bottom graph is just a different way to show how quickly things can spread. And the top line is COVID, and one sees that the infectivity rates, the ability to infect others, was astronomical. And this is what we faced early in the course of this pandemic. This is what many countries are still facing as we see spikes. The infectivity of these agents is such that we can quickly increase the masses. With an R naught of 2, for instance, 1 becomes 2, becomes 4, becomes 8, becomes 16, 32, 64, 128. You can see how quickly the numbers are increasing. And this is the problem that we face as a society. So we don't have lots of data. We've been in this disease a year, okay? And criticism has been leveled to the experts in the field that you said this at one point and now you're saying this. And that's to be expected. We learn as we go. We started by flying by the seat of our pants. We applied best principles that we knew from other infections. And then we modify our verbiage and our recommendations as we experience the illness and as we gather new data. And that's why the scene has changed. That has upset lots of people, I think wrongly so. That's the natural evolution of understanding a new illness that we're facing. And so right now we have little data available in MG itself about the immune suppression risk in COVID. We have to borrow from other diseases, such as multiple sclerosis, and we'll come back and talk about this. But it's a plea from me to you to participate for those of you who have had COVID, or should you get COVID, that your physician participate in disease registries. And myasthenia gravis has a disease registry, CARE MG, and I'll give you some insight to that in a moment. Our data is limited to our MG CARE registry. We have now about 280, 290 patients. And so there are too few patients to draw definitive conclusions. But what we believe, based on other diseases who use similar drugs and other viral infections that we've had experience with, that much of the immune suppressive drugs that we use increases only slightly or not at all the risk of COVID-19, with one exception. And that's the use of B-cell depleters, most common of which is rituximab. And there are a couple of others on the market. And the role of rituximab is based on, and its risk with COVID infectivity is based on our knowledge of disease mechanisms and the ability that this drug reduces antibody. But it's only an impression. We don't have good data yet. We haven't seen large numbers in the MG space of patients who have been on rituximab who've become infected. We do have data from the multiple sclerosis world that suggests that there is a slight increased risk in those who use B-cell depleters. And so our decisions of whether we use this particular drug or any drug, if you will, is based on our knowledge of the patient, the severity of their disease, and what of our other options do we have available at that moment in time. Now, in contrast to that, there's much press on the role of hydroxychloroquine and azithromycin, or what's commonly called the Z-Pak. There is no good scientific support for the use of hydroxychloroquine, which has the potential to aggravate weakness of myasthenic patients. Numbers of trials have shown that it's not effective to treat this disease. There is data to suggest that azithromycin may be helpful in selected COVID pneumonias early, but we know that azithromycin carries the risk of increased weakness in the MG patient. To use or not to use? That is the question. And the decision has to be made by the treating physician in concert with his consultative experts and the patient to use this drug if there is no other alternative, if they feel it's the best recourse for the patient at that moment in time. A task force was put together that has published their recommendations about treatment of MG in COVID-19, And I was part of that task force. It's led by Dick Nowak, Richard Nowak, and Sri Mopidi and Jeff Guptill. And it's our belief that patients should continue their treatment and not to stop existing medications unless it's specifically the recommendation of their treating physician. The risk of a myasthenic exacerbation and the outcome from that, we believe, far outweighs the risk that these medications have on acquiring COVID. There is no scientific evidence whatsoever that symptomatic therapies like pyridostigmine or 3,4-diaminopyridine increase infection risk, so we would not recommend their discontinuation. Although patients who are on immune suppression, we believe they should be extra vigilant, super extra vigilant with social distancing, mask wearing, and utilizing telehealth where appropriate rather than in-person visits until such time their clinicians have vaccinated, they've been vaccinated, etc. Now, let's talk about the registry, CARE-MG. It's multinational, it's voluntary, it's physician-reported, and we're tracking patients who develop COVID-19 and their outcomes. And preliminary data cuts of just top-line data are published on the MGFA website and updated periodically. And what we're doing is trying to identify patterns of risk and outcome. And this data cut is March 19. It was updated April 2nd, and so that's not here, but there are about 234 registrants. They come from 14 countries. The U.S. is the largest, and that should be 91. The U.K., 57. Iran, 31. Germany, 17. You can read it there. And so we beg, we plead, we ask that if you've had COVID and your physician has not put you in this registry, or if you develop COVID, please have your physician register you so that we can establish enough information to be able to make specific recommendations to you. All one has to do is Google CARE-MG. They're taken to the website. As of the 19th of March, where do we stand? There were 89% of the 234 patients who had laboratory proof of COVID, and there were 11% who were suspected of having the disease, but had not been confirmed by an antibody test. Of those patients, the majority had AChR positive MG. 5% had MuSK, 1% had LRP4, and 14% were seronegative. And then we had a small group that were unknown. These figures are similar to the overall demography of MG itself, and so we don't believe any one antibody subtype increases or decreases the risk to develop COVID. So what's happened to these folks? 36% have recovered. 45% on the left side in blue are still recovering, or we don't have the data yet. On the right in gray, 3% have not recovered at all. And unfortunately, in the bottom, 17% of patients with MG who've developed COVID die. These are sobering statistics. And I think it's a call to arms to perform the W's that we talked about, to be vigilant, to wash hands, wear a mask, social distance, and become vaccinated. And this is how you can help. Cover your cough, cover your sneeze, cover it with a napkin, air out your rooms, cover your elbow when you cough and sneeze, and wash your hands. Probably washing of the hands is one of the most important things you can do. And not simply just run them under the water and then dry them off, but literally take the time to use a soap, detergent, and wash them. And some people say you sing Twinkle, Twinkle, Little Star twice, and that does it. but you wash the bottoms, the tops, in between the fingers, etc. And you might say, well, what the heck is he telling me this for? I know how to do that. You would be surprised the number of patients we have in our clinic who don't understand what it means to vigorously wash the hands. You can help by wearing a mask. This is absolutely critical. And you don't wear it below your nose. As I said already, the nostril, the nasal passage, is the prime reservoir for the virus. And so it has to cover both the mouth and the nose. And you wear it in any building. You wear it in proximity to any individual. Now, if you're out riding a bike or out jogging by yourself and there's no one around, there's no need to. But make sure you have one with you, so should you come in contact, you can slip it on and then have a conversation of whatever. This isn't a political issue. This is a public health issue. And I know the whole problem has been politicized, and that's terrible, and it's unfortunate. Social distancing. We use the rule 6 feet between patients. In my Starbucks in the hospital, they have big circles with a tar heel, because we're the tar heels, spaced every 6 feet, and that's the circle you stand on until the person in front of you moves forward. 6 feet probably is okay in most instances. Some would argue that individuals who are speaking loudly, who are coughing or sneezing or yelling or singing, 6 feet is nowhere near enough space. But in general, maintain this 6 foot distance. Now, if you're walking in a hall and someone passes you and they're shoulder to shoulder to you, that momentary contact is not going to get you infected with coronavirus. And so don't worry about that. But if you're standing in a crowd, you're waiting in line for someone or something, make sure that there's 6 feet of space between you and the next individual. And why this all matters is sort of shown here. If we say that people are infecting with normal behavior, one infects 2.5 people in 30 days, they've infected 406 people. If we can cut this down by mask wearing, by covering our mouth or nose when we cough and sneeze, by not singing, etc., by social distancing, if we can cut these things down and we can get to our knots of 0.625, then in 30 days we've only infected 2.5 other people. Let's talk about vaccination. And let me start by saying vaccines do not cure coronavirus. The reason we vaccinate people are two things: to keep you from dying and to keep you out of the hospital. It does not mean you will not develop coronavirus. We just had a colleague the other day, a colleague of a colleague, who's vaccinated back in December and went to get on an airplane to go to a meeting that he had to be at, and had to have a PCR test done before he was allowed to board the flight. The PCR test was positive. He was a reservoir for virus. And therefore, he was capable of infecting other people. He was totally asymptomatic. No symptoms whatsoever. Never had any symptoms at all. But had come in contact and become infected, and I put that in quotes, with coronavirus, and therefore could infect other people. So vaccination will not cure you. It's to keep you from dying and keep you out of the hospital. So do I vaccinate? Yes, no, maybe, probably not, sure. Among those who are listening, I'm sure there's one of you at least who has every one of these thoughts. The community sampled patients And this is about 31,000, nearly 32,000 responses. When do you think you'll get a COVID vaccine? More than half said as soon as possible. 15% said never. And then the other question was, do you trust the vaccines? They were developed responsibly. A little more than half said yes. And about 12% absolutely not. 5% said no. 13% said not so sure. When we look at vaccine perceptions, this is the reasons why people are not interested in the vaccine. It's too new. More than half. One can become infected from a COVID vaccine. 8%. That's absolutely not true. You cannot become infected from a COVID vaccine. And you can see the reasons there. Safety, efficacy, side effects, discomfort. Side effects and discomfort in 44%. All vaccines have side effects. It's absolutely expected. The vast majority are very mild and do no harm to you, but you will have side effects. Some of the patients that have told me that they weren't going to get it is because the vaccine contains a microchip. Vaccines, even though they're made this messenger RNA, these are not things that are going to monitor you, your whereabouts, etc. And I asked the individual, do you have a cell phone? And they pulled out their iPhone. Your iPhone knows where you are 24/7, 365 days of the year. It is continually monitoring you and your whereabouts. And then, as we said, you can't get COVID-19 from a vaccine. People say, I don't know what's in it. But you've eaten bologna your entire life? You don't know what's in bologna. I don't know what's in bologna. I'm scared to think of what's in bologna. We know what's in the vaccine. We know how they're built. There are multiple vaccines under development, and I've listed them here. They're in various stages, and we have several that currently are in use throughout the world. These vaccines, and probably much of the problem has come from the terminology warp speed, which is the last administration's concept of how to build these vaccines, to do it fast. And yes, it was done quickly, but it was using technology that has been around for a long time. And yes, mRNA vaccines are new, but the technology is old. And it allowed us to leapfrog many other old methodologies and get to A, to B, to C more quickly than we would otherwise. But even then, our old vaccines are made quickly. Do you realize we make a flu vaccine in 6 months? We get a sense of what the flu is going to be, which viral strains, and then we create that vaccine in 6 months and have it ready for distribution and injection. As of March 12th, these are the companies that were making vaccines. And you can see the ones on the left that are already in use throughout the world. Most commonly in the United States, it's Pfizer, Moderna, and Johnson & Johnson. But there are others that will be coming. In other parts of the world, the Russian Sputnik 5 is available. And so these have all been developed using in the United States with very excellent quality methodology. So what kinds of vaccines are available? The most common, as we said, are the encapsulated mRNA vaccines. Pfizer, Moderna. Each require 2 doses. The time difference between the two is a little bit different. The viral vector vaccine, and these are killed viruses, so they are perfectly safe for a myasthenic patient. It's the AstraZeneca, the Johnson & Johnson, the Sputnik 5. One is 1 dose, the other 2 are 2 doses at various time intervals. And then we can take a virus-like particle, which is the Novavax vaccine, and create it. It too is quite safe for a myasthenic patient. And then in China and in the Middle East, there are 3 vaccines that use an inactivated virus. These too are safe from a myasthenic patient perspective. There are no live viruses in any of these. So you will not get the virus from the vaccine. I'm just going to skip that one here. So people say how it's not effective. It doesn't work. Well, it does work. Flu vaccines typically are only 45% effective. Some years they're down around 20% because we called the wrong shot and it wasn't the right virus. But we know that flu vaccine is 50% effective against influenza B, but only 30% effective against influenza A. And during 2019 and 2020, we're talking about 95, 94, 72% efficacy with the vaccines that we're using. The most common side effects are redness and swelling at the injection site, headache, some muscle pain, fever, chills, nausea, and up to 92% of patients. That's expected. That's appropriate. And it's not going to hurt you. It's going to make you uncomfortable, yes, but it will not hurt you. There are more severe side effects. I agree, but they occur at about 1% or less. Why these occur, we're not completely sure. Are they allergic to something within the vaccine itself? Or is the virus particle reacting with something they've been previously exposed to? We don't know. But 1% or less have a severe reaction. Now, people read the news and they're talking about the adverse events in clinical trials. And they say, "Whoa, this bothers me." When we do a clinical trial, from the time you sign the consent form to participate, anything that happens to you is an adverse event. If you stub your toe and get a bruise, that is an adverse event. One of my patients in one of my trials was on a skateboard with her daughter, got going too fast and fell off it and developed a huge bruise on her buttocks. That's an adverse event, and we report that, and it ends up in the statistics. If you develop a cold or a flu, that becomes an adverse effect. Was the latter related to the drug? Maybe. Was the first one? Absolutely not. That was just fooling around and fell and, we got injured. But it's still an adverse event. So be very careful what you read and don't interpret that as the end-all and be-all. As I said, none of these vaccines are live. They're all safe. In general, we do have some recommendations. If you're going to start an immune suppressive drug, we'd like you vaccinated at least 2 weeks before you start treatment. If you're getting plasma exchanged, be vaccinated shortly after your plasma exchange, not before your plasma exchange. If you're getting IVIG, we suggest you wait 14 days prior to the next scheduled dose. This is based on HIV studies. Rituximab, 3 to 5 months after the last course of rituximab infusion, longer if possible, but at least 4 weeks prior to your next infusion. If you're on eculizumab, there is no issue. There's no interaction. And if you're in a clinical trial, it's best that you talk with your study team. There are recommendations that have been made based on the drugs that are being used under study, and they're very specific to the drug that's being under investigation. So talk with the study team. So where do we stand? Less than 2% of the worldwide population is fully vaccinated. About 4% have gotten their first dose. 16% of the U.S. population is fully vaccinated, and 28% have gotten partial vaccination. Now, these numbers are different today since this was looked at on March 28th. So we're making progress, but we got a long ways to go. Why did I get vaccinated? I don't want to get sick. I don't want to die. I don't want to give the virus to my family, friends, and colleagues. I want to be able to see my grandchildren who live in North Carolina, and I've seen those, but I have a grandchild in Switzerland that I haven't seen in now almost 2 years. I'm tired of seeing death. But more importantly, I'm tired of comforting families who are not able to see their sick loved ones die. And I want to be able to grow my beard again. We need to flatten the curve. And with uncontrolled transmission, it looks like that in green. With all of the public health measures I've talked about, we can get this under control, and we can push that to the orange curve. And why is that important? Because our healthcare system nearly crumbled. In some countries, it is crumbling. In Spain and Brazil, the entire hospital system is an absolute disaster. And you come to the hospital and they say, we can't take you, go away. And you're out. We came close in my hospital. We had a dormitory starting to be converted to a COVID hospital to be able to handle the spike. But fortunately, with people's cooperation doing these things, we pushed the curve down. We flattened it out. There are a number of resources available to you as the MG patient through the USD Food and Nutrition Service, to the Department of Housing and Urban Development for resources, the CDC, of course, but probably most importantly, go to your state health department. So if you go there, just www.usa.gov/state-health, that will take you to a list. You pick your state. So let's act. Let's wear a mask. Let's stay 6 feet apart. Let's avoid crowds. And let's get vaccinated. This is not political. This is public health. We need your cooperation. Thank you very much for your time. Now, let's bring Dova back up and let's open this up for questions.
Thank you, Dr. Howard. We have a lot of questions. We'll see if we can get to all of them, and if we can't, we will try to get your questions answered afterwards. The first question is, I have only had MG for 1 year, and it was 2020. How can I know what the impact of COVID is on my attempt to manage my MG?
Well, I don't know your medical history in detail at all, but COVID risk to you is no greater than to anyone else and minimized by the things that we've talked about. And the only caveat is that should decisions be made that your physicians want to initiate selected treatments that will suppress the immune system, my advice is to be vaccinated first, if at all possible. And within the next few weeks, we should be able to vaccinate anyone 16 and older, and that will minimize your risk.
Great, thank you. Do you believe that one's IgG will determine SARS immunity years from now?
If you're speaking about your just basal IgG level in your body, absolutely not. That has no correlation unless you have immunoglobulin deficiency. And there are some genetic syndromes which produce that. I've not seen that in an MG patient. We do know that certain of our treatments, such as plasma exchange, have the capability of lowering our IgG levels. Dr. Jeffrey Guptill and I published a study looking at the ability of patients who are under chronic plasma exchange to mount an antibody response to things like tetanus, measles, etc., and all of those mechanisms are intact. In addition, the lowering of IgG with plasma exchange does not alter the immune system's ability to recognize a foreign invader. So it has the capability of recognizing, oops, here's a virus, turn on the signal, let's mount the attack, and let's produce antibodies to attack it. And that's all intact.
Thank you. The next question asks, my wife is LRP4-MG. Is there any information on specific types of MG being more or less susceptible to COVID-19? Are any of the available vaccines better or worse for MG patients? My wife has had the Moderna vaccine. She had rituximab treatments for 3 years. So she had rituximab treatments 3 years ago.
So there is no subset of myasthenia gravis that is any more susceptible to COVID than another. Regardless of what your antibody is, the COVID risk to you is the same. The vaccines, there is not one vaccine that is better for a myasthenic or another. And we have recommended you get whatever you can get. Take it. Don't wait, and you will still have protection. The fact that she was treated with rituximab 3 years ago, in most instances, should not alter her response to develop an antibody response to the vaccine. There are rare, very rare patients treated with rituximab who lose their ability to produce B cells. But even those individuals, we aren't sure yet what the risk is to them. So in general, any of the vaccines are safe. None of the antibodies in MG make a difference. Take whatever vaccine is available to you.
The next question asks, is an antibody test after vaccination a true indicator if one has gotten immunity?
That's an excellent question. At this point in time, we do not think so. But we don't have enough experience. All we know is that the antibody response reflects the fact that you have, now we're talking about antibody to the vaccine, not to COVID. The antibody response to the vaccine means that you've mounted a response. We know that with other vaccines, such as meningococcal vaccines, etc., doing serum titers of the vaccine has no correlate as to their protection level. So we don't recommend doing them. Once you've gotten vaccinated, if you have a anti-COVID titer antibody, then at some point in the recent past, you've been exposed to COVID. And maybe an asymptomatic carrier, for instance, like this other individual that I spoke about earlier.
Okay, the next question is, what effect does weekly IVIG have on the efficacy of the Pfizer shots?
The efficacy of weekly IVIG has no specific effect on Pfizer. There are some theoretical reasons why it would potentially dampen the amount of antibody produced, but that appears not to be of major concern because all of the preparatory mechanisms to recognize virus, to turn on the attack, mount the attack signal, are all intact. In MG, we don't have enough data yet to know if there is any significant impact on that. And that's why this registry is becoming critically important to us. But at the moment, we do not believe that the chronic use of IVIG would impair your ability to mount an appropriate response to vaccination.
Thank you. The next question asks, what is the danger if a person who is fully vaccinated is exposed to a person who tested positive for COVID? Should they be tested and should they isolate?
So that's another great question. So I guess I would answer that by saying, were you practicing the W's? Were you wearing a mask in proximity? Were you washing your hands? Did you maintain social distance? Were you outdoors? Clearly, the vaccinated individual is at less risk, but is not an absolute guarantee that you won't have an infection. The recommendation from our health department here in the state of North Carolina is that they would not do any testing for COVID unless one develops symptoms of a respiratory illness. So should you develop a cough, a fever, nasal discharge, then yes, you should be tested appropriately. But short of that, no. Should you social distance or isolate? I would probably stick close to your bubble for a week and not go beyond that. After that, then I think you're probably fine. But that's only my personal recommendation. I've not seen a specific recommendation to that.
The next question asks, is ivermectin possible for COVID-19? I guess, is that a treatment for COVID-19?
I'm not familiar with the drug, so I can't answer that.
Looks like ivermectin.
It is actually a therapeutic compound for parasitic worms. It has no effect on any virus whatsoever, so it is not a treatment for COVID-19.
Thank you. What are your thoughts on having the timing between vaccines lengthened from 3 or 4 weeks to 4 months for those with MG?
I don't have any reason why I would want to lengthen the interval. The first injection is what we call a priming injection. The second injection for those vaccines that require it is the boost. And there are issues as to what that interval should be. Now, a day plus or minus doesn't make a bit of difference. If it's recommended to go 3 weeks, can you go 5 weeks? We don't know. There is no data. The trials were not designed to answer those questions. And while it is possible for any of these scenarios, we just do not have data. So my recommendation is that you follow the manufacturer's instructions. And if they say revaccinate in 21 days or 28 days, for Pfizer, Moderna, that's what you do.
The next question is the vaccine less effective if someone is immune suppressed?
No, we do not believe the vaccine is less effective if you are immune suppressed. The immune system's ability to recognize that you have an infection is totally intact. The ability to produce an antibody response to that infection is completely intact, with the one exception of individuals who are possibly on rituximab. And that family of drugs may have an impact, but we do not have adequate data yet to make an absolute statement.
The next question asks, which vaccine is the best to take for MG patients?
There is no one vaccine that is better than the other for the MG patient. They're all efficacious. The recommendations I have given to my patient are whatever you can get, you take. It's more important that you be vaccinated than to wait and pick and choose.
The next question is, does the MG Care Registry want data on people with MG who have not gotten COVID or have been vaccinated? Is that valuable data?
No, the Care MG Registry has only been designed for patients with MG who have COVID.
The next question is, I had the Pfizer vaccine and found that my MG actually strangely improved temporarily. I had no MG symptoms for several days after the vaccine, which has not happened since diagnosis. Have you heard others say this? Is there some reason for this? Could this type of vaccine be useful in autoimmune disease treatment in the future?
Yeah, that's a fantastic observation, and I would hope that your physician records all of the details of this and then files it away in case something else like this pops up. I have not heard of a similar case in MG. You know, as we augment aspects of the immune system, there's a lot of the immune system we don't know what it's doing. And so is there, as we build antibodies, do we have a preference for building selected type of antibodies and turning off other antibodies? I'm speculating here because I don't have an accurate answer, but one could envision that. Or there are other elements of the immune system that have turned on that have interfered with your myasthenic antibody from doing its role. It's a first that I've heard of. It's something that should be noted so that should anyone else have a similar effect, then it gives us a potential way to look and explore further.
Our next question is, how do you counter when people say that some deaths were not caused by COVID, but by flu or something else?
Well, not being directly involved in their care, I don't have any of the details. I don't know. I don't have an answer for that question.
Okay. We are going to take one more question. We have a lot of questions that we will try to get answered afterwards because we just can't get to them all and stay on time today. So our last question is, you mentioned regrowing your beard. What part does a beard play in contracting COVID?
Well, that's actually an excellent question. So in my hospital, if we're directly involved with patients, we have to shave to wear N95 respirator masks. And a beard does not allow a full seal to the skin. So it's a potential entry for virus to enter. And in the hospital, we're seeing patients with COVID and all. And so it's to facilitate our protection. I guess Dova has left. So I want to thank all of you for your participation, your questions. They're excellent. And I hope we were able to answer at least some of them to your satisfaction. And Dova will try to get answers for some of the others as well.
I will. Thank you so much, Dr. Howard. We are going to now take a break for 10 minutes, and then you can come back into the theater, and we will be starting Navigating Insurance Disability panel coming up shortly. So thank you all very much.
Take care, everyone. Stay safe.